Welcome to Weekly Neurology Deep Dive, produced by Americ Gavanini. Today, we're diving into a really interesting paper, one that's quite relevant for clinical practice. It's Influenza with and without Oseltamivir treatment and neuropsychiatric events among children and adolescents by Antoon, Williams, and colleagues. It was just published in JAMA Neurology on August 4, 2025. Now, before we get started, just a quick reminder. This deep dive is purely for educational purposes. We don't have any commercial goals here. It's really just a summary of the source material. And we definitely recommend you read the full paper yourself for all the context and details.
Absolutely. And this topic, well, it's been a source of concern for quite a while, hasn't it? The question around oseltamivir safety, especially these neuropsychiatric events, it's been debated. This paper, though, it brings some significant new data to the table, particularly for kids and adolescents. So our aim today is to really break down the key findings from this pretty comprehensive retrospective cohort study.
Okay, great. So let's kick off with a practical summary for those of you maybe short on time. For neurologists, the main takeaway here seems clear. Influenza itself, in children and adolescents, significantly bumps up the risk of serious neuropsychiatric events bad enough to need hospitalization. But importantly, treating with oseltamivir during the flu, that was linked to a big drop, about 50%, in how often these serious events happened. And it looks like this protective effect was mostly driven by fewer neurologic events. So the findings really support using oseltamivir to prevent these flu complications, and they don't back up those long-standing public worries about the drug increasing neuropsychiatric risk. Actually, quite the opposite. Okay, now that we have the headline finding, let's dig into how they actually got there. This is where it gets really interesting. Looking at the study's design, their goal was pretty specific. Figure out the link between flu, oseltamivir, and these serious neuropsychiatric events in kids. How did they tackle such a complex question?
Well, the methodology here is quite robust, I'd say. It was a retrospective cohort study, sure, but crucially, it used population-based ambulatory data from Tennessee Medicaid. That means they're looking at real-world data across a large, diverse group. It gives the findings, quite a bit of weight in terms of generalizability.
Tennessee Medicaid data.
Yeah.
That sounds like a huge pool. How many kids were involved and over what period?
It was massive. The study covered the 2016-17 and 2019-20 flu seasons. They included almost 700,000 eligible children, 692,295 to be exact, ages 5 to 17. Median age was 11, and about half were female. And get this, they accumulated over 19 million person weeks of follow-up. They also made sure to follow the strengthening the reporting of observational studies and epidemiology, that STROBE guidelines for reporting. It's a very solid data set.
Wow, 19 million person weeks. Okay, so with all that data, how did they actually categorize who was exposed to what to compare them fairly?
Right, that's key. They used a person-day approach, which is very precise. Participants were assigned to one of 5 mutually exclusive exposure groups each day. These were untreated influenza, treated influenza, then a post-treatment period that's after finishing oseltamivir, but still within the defined influenza period. Then there was influenza prophylaxis, and finally, a no-exposure group. The main comparison, the real core of it, was treated flu versus untreated flu. That lets you isolate the treatment effect.
Okay, that makes sense. And confirming the flu cases and the oseltamivir use, how did they pin that down in such a large administrative data set?
They used outpatient international statistical classification of diseases and related health problems, 10th revision codes for influenza diagnosis. These codes actually have a pretty high positive predictive value for lab-confirmed flu, which helps minimize misclassification. Influenza exposure was defined as the diagnosis day plus the next 9 days, so a 10-day window. Oseltamivir exposure came from pharmacy dispensing data starting day 1 of dispensing through the end of the supply, usually 5 days for treatment. And, since flu often lasts longer than the 5-day treatment course, looking at that post-treatment period separately was important. They also used strict flu season definitions and focused on outpatient or emergency department diagnoses to try and keep the severity comparable between groups.
That's really meticulous exposure definition. What about the other side, the outcome? How did they define a serious neuropsychiatric event requiring hospitalization? That sounds like it could cover a lot.
It could, but they used a validated algorithm with a high positive predictive value, around 90%, to identify these events. And we're talking serious events needing inpatient care. Neurologically, this included things like seizures, encephalitis, altered mental status, ataxia, movement disorders. Psychiatrically, it covered severe mood disorders, psychosis, hallucinations, and suicidal or self-harm behaviors. They did initially cast a wider net, including things like headache or dizziness, but crucially ran sensitivity analyses focusing just on the most severe, clearly defined events.
Got it. And controlling for other factors. I mean, kids who get oseltamivir might be different from those who don't for other reasons. How do they account for that?
Good point. They used Poisson regression to get incidence rate ratios, and critically, they adjusted for a whole host of covariates measured daily. Things like age, sex, race, ethnicity, the specific flu season, any pre-existing neurologic or psychiatric conditions. Also, known risk factors for flu complications, even things like antipyretic use and general healthcare utilization patterns. They used a 365-day look-back to capture these conditions and excluded time spent hospitalized for other reasons to avoid bias. It was a really thorough adjustment strategy.
Okay, so a huge data set, careful definitions, robust adjustments. What did they actually find? How many events did they see overall?
Right, the results. So across the study period, they recorded 1,230 of these serious neuropsychiatric events. 898 were neurologic and 332 were psychiatric. That's a decent number to analyze. And looking at the flu episodes themselves, about 151,400 of them, roughly two-thirds, about 67% got oseltamivir. Interestingly, even among those considered high risk for flu complications, only about 60% got an antiviral.
Okay. And what were the most common types of events? Did it differ overall versus during the actual flu period?
Yes, it did, and that's quite revealing. Overall, mood disorders were most common, about 36%, followed by suicidal or self-harm behaviors at about 34%. But when you look specifically at events happening during an influenza exposure period, seizures jump to the top, accounting for about 34% of those events. It really highlights, the acute neurological impact the virus itself can have. Makes you think about the importance of prompt treatment.
Seizures. Wow, that is striking. What about the timing? How quickly did these events happen after the flu diagnosis?
Very quickly. For kids who had an event during their flu episode, the median time from diagnosis to the event was just 1 day if they were untreated. It was slightly longer, 2.5 days if they were treated. And about three-quarters, 77% of all events happened within 5 days of the flu diagnosis. It underscores how acute these complications are.
Okay, so now for the main event, the core finding. What did this massive amount of data show about oseltamivir's role in all this? Did it help, hurt, or make no difference?
This is the crux of it. Compared to untreated influenza, the risk of having one of these serious neuropsychiatric events was significantly lower for kids treated with oseltamivir. The adjusted incidence rate ratio during treatment was 0.53, and even in the post-treatment period, it was 0.42. So we're talking about nearly cutting the risk in half. That's a really substantial protective effect. It strongly argues against oseltamivir being the problem and actually points to it being part of the solution, mitigating the virus's effects. And just for context, the rates were way lower in the no exposure group adjusted incidence rate ratio of 0.188 and the prophylaxis group adjusted incidence ratio of 0.10 compared to untreated flu. Shows how much risk the infection itself carries.
A 50% reduction, roughly. That's huge, especially for events needing hospitalization. You mentioned it was driven more by neurologic events. Can you elaborate, especially on the psychiatric side, given the historical concerns?
Exactly. The sub-analysis really clarified this. The protection was strongest for neurologic events. Adjusted incidence rate ratio 0.45. So very effective against things like seizures, altered mental status. For psychiatric events, the adjusted incidence ratio was 0.80. Now, numerically, that's lower than 1, suggesting perhaps some protection. But the confidence interval was wide. It crossed 1. So statistically, we can't say it significantly reduced psychiatric events like it did neurologic-wise, but critically, it absolutely does not support the idea that oseltamivir increases the risk of psychiatric events. That concern seems unfounded based on this data.
Right. No increased risk, but maybe not the same level of proven protection as for the neurologic side. How confident can we be in these overall findings? Could something else be explaining this apparent protection?
They really put the findings through their paces with sensitivity analyses, changing definitions, excluding certain covariates like race ethnicity, looking at time-varying risk, the results held up, and they calculated something called an E-value, which came out at 3.2. Basically, that means an unmeasured confounder would need to be associated more than threefold with both getting oseltamivir and having an event to completely wash out this protective effect. That's a high bar. Plus, that negative control outcome appendicitis showed no link to treatment. That boosts confidence that the neuropsychiatric link is real. They also ran analyses excluding less specific events like headache or dizziness, and others focusing only on primary diagnoses, and the strong findings for neurologic events remained consistent.
Okay, that sounds pretty robust. This study really seems to push back against those lingering worries in some older, less clear studies. So stepping back, what's the big picture implication here for neurologists seeing patients every day?
Well, I think it powerfully shifts the focus. It strongly suggests the influenza infection is the main culprit behind these serious neuropsychiatric events in kids. And maybe more importantly, that oseltamivir treatment actually reduces that risk. It helps protect against these complications.
Oh,
This is a really crucial distinction. Previous meta-analyses gave mixed signals, maybe because they mixed treatment and prevention groups, or looked at events happening way after treatment stopped. Given oseltamivir's short half-life and limited entry into the brain, linking it to lead events was always a bit questionable. This study's day-by-day tracking is much more precise.
So it builds on, or maybe refines, earlier work. How does it stack up against other observational studies, and what were the key strengths that let this study be so definitive?
It aligns with some other observational studies that hinted at a decreased risk with oseltamivir, but this one overcomes common limitations, like using less reliable outcome definitions, including those distant events, or struggling to account for underlying conditions. The strengths here are really the precise person-day exposure tracking, using those validated flu codes, the validated outcome algorithm, and that comprehensive set of sensitivity analyses, including the negative control. Oh, and also meticulously tracking antipyretic use, since things like fever reduction could influence delirium risk. It adds another layer of careful control.
A very strong design. But no study is perfect, especially with real-world data. What are the limitations clinicians should keep in mind here?
True, there are always limitations. Residual confounding is always possible. Maybe factors like how consistently kids take other chronic meds or just differences in seeking healthcare couldn't be fully captured. They also couldn't account for specific flu strains or vaccination status, though, as you know, guidelines generally recommend oseltamivir regardless. And they didn't have data on symptom duration before diagnosis. So it's possible the treated group presented earlier, which might itself lead to better outcomes, though that's also just good clinical practice. Also, a key point. This focused only on serious events needing hospitalization. Milder events weren't captured. And finally, it's Tennessee Medicaid data. While large and diverse, you always have to consider generalizability to, say, commercially insured or uninsured populations elsewhere.
Okay, limitations noted. But considering the main finding that significant reduction in serious events, does this warrant a potential shift in practice? Should we be thinking about recommending oseltamivir more broadly for pediatric flu?
I think this study provides very strong ammunition for that discussion. The evidence clearly shows oseltamivir treatment is associated with a lower risk of serious neuropsychiatric events. From our perspective as neurologists, preventing severe things like seizures or encephalitis linked to the flu itself is a major goal. While we acknowledge the limitations' generalizability, focus on severe events, the data strongly supports oseltamivir not only being safe in this context, but actually protective. It should definitely factor into clinical decision-making and, importantly, help reassure parents and caregivers about the drug's safety profile when used for influenza treatment. It really bolsters the argument for using it, especially when flu is confirmed or highly suspected.
Right, so let's just circle back and reiterate that practical summary for everyone listening. Key message. Influenza infection itself significantly raises the risk of serious neuropsychiatric events needing hospitalization in kids and teens. But crucially, treating of the oseltamivir was associated with about a 50% reduction in these events, especially neurologic ones like seizures. So these findings strongly support using oseltamivir to prevent these flu-related complications, and they really counter those older concerns about the drug increasing neuropsychiatric risk.
exactly. It's a reminder that the virus can have significant neurological effects, and that targeted antiviral therapy seems to play a protective role. It's less about just symptom management and more about potentially preventing severe outcomes.
A very important perspective shift. We definitely encourage you to check out the full paper, Influenza with and without oseltamivir treatment and neuropsychiatric events among children and adolescents in JAMA Neurology. Thank you for joining us for this weekly neurology deep dive. We hope this breakdown was valuable for your clinical practice.